Hi, I'm Dr. Carey Hemmelgarn. Today we're going to talk about polyuria in dogs.
This program is brought to you by Merck Animal Health.
So I'm Dr. Carey Hemmelgarn. I'm going to tell you a little bit about myself today. So I am a small animal critical care specialist. I went to veterinary school at Washington State University. I followed that by doing a 1-year rotating internship in small animal medicine. And then I followed that up with a 3-year residency in emergency and critical care. My current job includes working on the clinical floor as an emergency clinician seeing triages and managing our intensive care unit and the cases in our intensive care unit. I'm also the co-founder and the CEO of a company called IntensiVets. It's an online training platform for continuing education for veterinarians and veterinary technicians. I love educating the veterinary profession, and that's why I'm so excited to be here with you guys today. And today we're going to talk about polyuria in dogs. Polyuria is described as excessive urine production. What does excessive mean? Excessive means that urine production exceeds 50 mils per kg per day. Just to give you a little line of reference, a normal urine output is 1 to 2 mils per kg per hour. Most commonly, patients with polyuria will also have polydipsia or increased thirst that accompanies the increased urine production. Primary polyuria is when the kidneys are unable to conserve water. This can be caused by many disease processes. These diseases can include osmotic diuresis, such as with diabetes, an antidiuretic hormone deficiency, or renal insufficiency to ADH. Primary polydipsia can cause polyuria. The first step in working up a patient that has polyuria involves taking a thorough history, including an age, the duration of your clinical signs, any current medications they're taking, what their appetite's been like, very importantly, what their water intake is, and what their weight history is. Are they losing weight? Are they gaining weight? When taking a history, you always want to determine if a patient has polyuria versus urinary incontinence versus plaqueuria. I'm going to go further into how to delve into those differences. Urinary continence is seen in middle-aged to older pets with females overly represented. They're noted to have urinary accidents when sleeping or laying down. Plaqueuria is a little different than urinary incontinence. That's due to frequent urinations, often with increased urge to go to the bathroom. Patients can have polyuria and have urinary incontinence and plaqueuria, or a combination of one or all of them. After a complete history, then you need to do a physical exam to continue to help you narrow down the causes of your clinical signs. You're looking for things like an enlarged lymph node, which would give you more likely that you're concerned about hypercalcemia, underlying neoplasia, all of those that could cause increased urine production. Or you're looking for cranial organomegaly, which could give you an idea of hyperdrenocorticism, which puts that higher up on your list. Small changes on your physical exam that could be helpful, such as a cataract, could indicate potential underlying diabetes. So never underestimate the power of your physical exam and being able to give you further clues onto what's going on with a patient. Diagnostics are going to be the next key steps to help you better diagnose your patient. Your CBC, you're going to look for an anemia, which maybe gives you more concern about underlying kidney disease, or a lymphocytosis, maybe that gives you further indication that there's underlying cancer. Your chemistry panel, you're going to look at their renal values, what their blood glucose is, their liver values, and their calcium. The urinalysis, a polyuric patient should not have concentrated urine. You're also going to look for evidence of bacteria, which could potentially lead you to a urinary tract infection and more likely plaqueuria. And you're looking for a presence of glucoseuria if you're trying to diagnose a diabetic patient. Chest x-rays are useful to look for underlying neoplasia and rule out metastasis. The abdominal ultrasound can be a very useful diagnostic tool to keep helping you with your evaluation of this patient. You're looking for the evidence or presence of neoplasia, enlarged adrenal glands, which could give you an idea further to look for Cushing's disease, and you're looking at their urinary tract to look for bladder stones, tumors, polyps, any of those. If these results are normal, you can rule out for other reasons of polyuria, then urinary continence may need to be considered. This is usually secondary to hormonal imbalances that occur after spay or neuter, but can also happen in older age as they lose muscle tone. So there are a few medication options for patients that have urinary incontinence. One of them is an estradiol derivative medication that can help with estrogen responsive urinary incontinence. Phenylpropanolamine is also another medication that could be used. With phenylpropanolamine, there are some side effects, so we always want to weigh the pros and cons when determining which of these medications would be best for a patient. Ectopic ureter is a congenital problem that can cause urinary incontinence due to the ureter opening into the urethra in an abnormal location and can in some cases cause urinary incontinence. Contrast studies or cystoscopy may be further needed in these cases to make a diagnosis and make a best for treatment plan. Polyuria is again seen most commonly in patients that have underlying urinary tract infections. So if you do have a patient on your urinalysis that you see evidence of bacteria, then sending out a culture to further isolate what type of antibiotic to treat it with and getting them started on a course of antibiotics and looking for a resolution of signs is very important. If you have a patient that has recurrent urinary tract infections, it's always important to look for whether there's underlying causes for that, whether that is that they have an involuted vulva, whether they have bladder stones, or whether they have things like diabetes that could predispose them to have recurring urinary tract infections. All of those are things you can further investigate. And lastly, if you do diagnose that a patient has diabetes on your workup for reasons for polyuria, that's going to be seen if you have glucoseuria in your urine. Also, sometimes you'll find glucoseuria and ketonuria, so all of those can be very helpful in diagnosing diabetes. Next steps is talking to owners about how to manage diabetic patients at home and what to look for, how to manage their feeding schedules, when to give insulin. All of that's going to be the next part of your treatment options with those owners. Lastly, there are a few other sort of more rare manifestations of pets that have polyuria. So anything that can cause underlying kidney disease can cause polyuria. So every once in a while we'll come up with a patient that has things like leptospirosis that can present with polyuria. So it is always important to look for things like looking to see what their liver values and their kidney values are, and looking to see if they are potentially a patient that could have been in an endemic area where leptospirosis would be higher on our differential list, although it's not always an underlying cause of polyuria. So we're going to talk about a case of a patient that could come potentially into your hospital and what would be ideally the next diagnostics to help work up their polyuria. So we're going to talk about a hypothetical patient. So we're going to talk about an 8-year-old, potentially slightly overweight female lab that comes into your hospital. The history is that over the past 1 to 2 months, she's been having intermittent accidents overnight while sleeping, but she's also been asking to go outside frequently. She'll wake up in the middle of the night asking to go outside, and she will urinate frequently outside when she's let outside and throughout the day. So again, we're faced with a decision. Is this a case in which she has primary polyuria, where she's making excessive amounts of urine? Is she having urinary incontinence, where she is leaking urine? Or is this something where she's having plaqueuria, where she feels like she constantly needs to go out and go to the bathroom, and that it isn't necessarily a case of her having more urine than just an increased urge to go out? So again, always going over history is very important. Sometimes asking owners questions like, when she goes outside, is she urinating large amounts, or is she urinating only very, very tiny amounts but very frequently? With polyuria, we would expect for her to be urinating fairly large amounts when she's going outside and going to the bathroom, where with plaqueuria, we would expect for her to be urinating only small little amounts, potentially sometimes straining, and sometimes there can be blood in the urine when she is. And so in this case, when we're talking about this hypothetical patient, when I get an answer from the owners, they describe that she's going outside and that she's urinating small amounts frequently. and that it isn't large volumes, and that when she has accidents in the house, it tends to be small volumes, and that she's straining to urinate sometimes. So again, going down the road of which diagnostics are necessarily going to be the most useful in this case. And so in that case, we talk about doing things like baseline blood work. We're going to look to see what her red blood cell count is, her white blood cell count, what her platelet count is. In this case, in this hypothetical patient, she's got an elevated white cell count. So maybe that puts things like urinary tract infection a little bit higher on our list of what could be going on. We're going to look at our chemistry panel. We're going to look to see what her kidney values look like, what her liver values, her electrolytes. We're going to look and see if any of those are abnormal. And most importantly, we do want to make sure that we don't see any evidence that she's diabetic, and so we want to make sure her glucose is normal. In this case, her glucose is normal. Her liver and kidney values are pretty normal and what we would expect for her age. And then we're going to get a sample of urine. Ideally, this would be a sterile sample, so if you can get a cystocentesis, that would be ideal because we want to minimize any chances of iatrogenic bacterial contamination. So we want to make sure that we get a sterile sample that we could potentially send out for a culture. So we're going to get a sample of that urine, and we could do an in-house stick if we have one, or we can always send it out to an external lab to do a full urinalysis. We're looking to see what her white blood cells, her red blood cells, we're looking to see if we see any evidence of bacteria. And again, we want to make sure that we don't see glucoseuria, as we want to again make sure that we aren't dealing with a case of diabetes. In this case, we did find that there's evidence of bacteria on her urinalysis. And in that case, we did send out a sample for a culture just to make sure that we are dressing it with the most appropriate form of antibiotics. We always want to send them home with a course of antibiotics because we don't want them to be feeling or uncomfortable until we get those results back from the lab, which can take about 3 to 5 days depending on your lab and their turnaround. So we do always want to get them started on a course of antibiotics. If we don't know for sure exactly if that's going to be the correct antibiotic, we want to choose what's going to be our best case first line antibiotic. If she's had a previous history of multiple urinary tract infections, we may need to choose a bigger gun of an antibiotic, but starting with something like amoxicillin or Clavamox are always potentially a good choice as long as they don't have any underlying allergies to those medications. And then sending out a sample to the lab to make sure those are correct antibiotic choices would be great. Ultimately, we can do further testing, specifically if this pet has had multiple urinary tract infections. Necessarily the next step that I would recommend if I were working up this case would be to do an abdominal ultrasound. So the abdominal ultrasound is going to give us an idea, is there underlying stones that could be potentially a nidus for that bacterial infection? Is there what we don't want to see, a mass or a polyp in the bladder that could be causing a nidus for that bacterial infection, and that bacterial infection is actually secondary to something else going on? And so in those cases, an abdominal ultrasound is really good in ruling out things like types of masses, cancer, bladder stones, all of those. And we want to look and see. Sometimes we just see things like a thickened bladder wall, which would make us more consistent with cystitis, and we obviously don't want to see any evidence of things like pyelonephritis or any inflammation around the kidneys or anything that could give us an indication that potentially that infection has traveled more upstream. So that's always things that we want to look for. If at any point you're noticing some changes, then potentially considering doing further diagnostics. If you see things like a mass or a polyp, there are other treatment and diagnostic options you can try to go down. If you're very concerned that there could be an underlying cancer that's causing a nidus for this bacterial infection, and that's how we get around to diagnosing it, doing things like sending out a urine sample for BRAF testing is a really good, minimally invasive test to try to help get an answer to your clients and also for this pet about potentially underlying cancer going on in the urinary tract. And then you always want to see how they're doing as a follow-up. If it is all of her signs are secondary to a urinary tract infection, you want to see an improvement within about 2 to 3 days of getting started on that antibiotic. If you don't see an improvement, then potentially we need to wait for the culture and see about a different antibiotic, and that maybe we aren't targeting what we need to. or that there is something else that's causing her clinical signs and we need to dig a little bit deeper or go down the road of doing further diagnostics. And in some cases, we don't get the option of doing all of these tests. And so in some cases, we'll be very limited and say, I don't want to do any tests and I just want to try to treat prophylactically for a course with an antibiotic and see if we see results. And that may be something that we do have to do. In those cases, if we don't see an improvement, then we have to circle back and go down the road of doing other diagnostics, such as full blood work and the urinalysis and the culture and the ultrasound, and doing all of those things if we don't see the response that we're expecting. But this would be an ideal stepwise to work up a patient that's potentially having polyuria. In this case, seems a little bit closer to having plaquuria signs. That's everything for polyuria. If you'd like to learn more, please follow me at Intensivets on social media. Please like, share, comment on this video. Thank you so much for joining us today.